Dear colleagues, thank you very much. I actually wanted to start that we just heard a lot about the burden of volume overload, and I want to talk about the quantification of volume overload now and oxygenation. So the reason, or we have many reasons for volume overload in congenital heart disease, and so we're going to focus during these 2 days on intra and extracardiac shunts, atrial septal defect, ventricular septal defect, PDA, or more complex congenital heart disease with volume overload and without deoxygenation, AVSD, totality of fallow, abnormal drainage of pulmonary veins, truncus arteriosus, and the really complex congenital heart disease with univentricular hearts, where we actually want to have shunts. They're shunt dependent, and we create shunts and enlarge shunts to have a sufficient circulation. Then we have all the operated congenital heart disease, the different palliation stages where we put BT shunts or ductal stenting, anastomosis, Waterson anastomosis, Potson anastomosis, and so on. So the consequences of volume load, we haven't heard about it yet, but so just in general, we have the left to right shunt, which is actually either promoting pulmonary volume and pressure overload and left heart dilation, or pulmonary volume overload and right heart dilation. Then we have the right to left shunt with the clinical sign of cyanosis in uncorrected congenital heart disease, arteriovenous malformations, veno-venous collaterals, or Eisenmenger syndrome. So in the end, we have the problems of heart failure, cyanosis, and pulmonary hypertension, which we want to tackle and which we want to prevent. So we try to be as precise as possible in quantifying. So what do we actually want to quantify? We want to quantify left and right ventricular size and function. We want to quantify shunt volume, QPQS, and pulmonary arterial hypertension, and the reversibility of high resistance. Why do we want to do that? We want to optimize time and type of treatment. We want to optimize treatment outcome and monitor treatment outcome. And how we can do it, we can use cardiac catheterization, echocardiography, or magnetic resonance imaging. So for the quantification of ventricular size and function on a daily basis, we use 2D or even 3D echo, but have the limitations of poor acoustic windows, limitations in border definition, and in the 2D echocardiography, we have the problems of geometric assumptions we made who lead to inaccuracies in quantification. So for quantification of ventricular size and function, we actually have MRIs, the preferred reference technique. We have the complete volumetric data set and can quantify size, function, and muscle mass of the right and left ventricle. Since 2010, we have the sex-specific pediatric percentiles for ventricular size and mass, which we use as reference values. So we have those values for boys and girls between the age of 8 and almost 20 years. For the quantification of shunt volume, we have to assess cardiac output, the systemic and the pulmonary blood flow, and actually have to assess stroke volume. And here again, we can use cardiac catheterization, echocardiography, or magnetic resonance imaging. In cardiac cath, we can angiographically quantify stroke volume. However, stroke volume measurements are limited here by the 2D nature and overestimation in case of shunts or valve regurgitations. Well, the actual gold standard in cardiac catheterization to quantify cardiac output is the use of principle of Fick. However, there again, in most of the cases, we take the assumed oxygen uptake and not the individual remeasured oxygen uptake, divided by the arteriovenous oxygen difference, and this is also a limitation factor. In case of shunts, we use the mixed venous saturation from measurements in SVC and IVC. In postoperative management, we can use the equation a little bit further simplified in order to manage, for example, patients with normal stage 1, in order to optimize ventilation treatment, hemodynamic treatment, and transfusion policy. Another quantification of cardiac output is thermodilution in cardiac catheterization. However, the limitations are said to be intra and extracardiac shunts, valvular heart disease, and pediatric population. So this doesn't seem very suitable for our patient cohorts. However, recent studies have actually suggested to use thermodilution with the probe in the pulmonary artery and in the aorta, and actually measure systemic blood flow and pulmonary blood flow and calculate the QPQS. In echocardiography, again on a daily basis, we can quantify stroke volume by using the left ventricular outflow tract diameter and the velocity time integral. And if we want to calculate QP to QS, we can just do this for the right ventricular outflow tract and the left ventricular outflow tract. However, recent studies have also shown here that echocardiography underestimates stroke volume. And this is probably the case because the assumption in the formula is that we have a circular left ventricular outflow tract. However, in many cases, we see that the outflow tract is elliptical, and so an underestimation of stroke volume is the case, inaccuracy of QP to QS, and probably what is more important, since the stroke volume is part of the continuity equation, we actually have a problem in underestimating aortic valve area and actually quantifying or diagnosing patients with a too high of aortic valve stenosis. Real-time 3D echocardiography actually can be used in order to quantify the left ventricular outflow tract better, and the study has shown that actually more patients had elliptical than a circular left ventricular outflow tract, and however, using the real left ventricular outflow tract dimensions could actually solve the problem. Real-time 3D Doppler echocardiography has also been used in order for flow volume quantification through a VSD in an experimental setting, and perhaps will reach the clinical routine. Something that has not reached the clinical routine yet is 4D flow echocardiography. Here on the left side, the usual color flow Doppler, and on the right side we see 4D flow echo, also in the ventricle. And this is a technique which has the velocity signal in 3 directions and not only in 1 direction. We can actually visualize blood flow patterns. It's Doppler angle independent and might improve flow quantification in the future. Let's come to magnetic resonance imaging. So stroke volume can also be quantified doing volumetric analysis. However, here again we have the problem that it's overestimation of, in case of valve insufficiencies and shunts. What we rather use for QPQS calculations are the flow measurements. So we can either use 2D or 4D flow measurements. We measure the absolute forward flow in the aorta and the pulmonary artery and calculate QP to QS. But no technique is perfect, so also in magnetic resonance imaging, we have problems with perhaps underestimation of stroke volume in cases of turbulent flow profiles. So here again, we have to look how are the flow profiles and measure at the right level in order not to make mistakes. But 4D flow, for example, has other advantages in shunt patients. So we have visualization and selective quantification of blood flow. Here on the right side, on the left side, we see the right upper pulmonary vein inserting into the SVC. However, in those angiographic pictures, sometimes it's difficult to distinguish whether it is really an insertion into the vessel or whether it's just a really close anatomical relationship. But if we actually visualize the blood flow, and we can see that the right upper pulmonary vein actually is really, the blood is flowing into the right atrium with the SVC and the IBC. And if there's a concomitant atrial septal defect or sinus venosus defect, we can actually also use 4D flow for selectively quantifying the flow through the atrial septal defect next to the pulmonary vein. And in complex PAPVD, we can also visualize flow profiles here in the left upper pulmonary vein flowing into the vertical vein and the Nordmeyer vein. And actually, we can also visualize right pulmonary veins also flowing into the left upper pulmonary vein and perform quantifications of selective vessels. This is also used by other groups in monitoring post-treatment outcome in PAPVD. In the upper row, we have the pre-treatment anomalous drainage of the pulmonary veins. And in the lower row, we have the post-operative outcome without any signs of stenosis. Other groups also publish case reports, for example, for visualization and selective quantification of a residual shunt after surgical VSD closure. This was actually myocardial infarction VSD, which was closed with the patch, and postoperatively the left ventricle, so blood was flowing from the left ventricle in between the patch and the septum to the right ventricle. Another topic we can address with 4D flow or with 2D flow quantification is the quantification of collateral flow, for example, in Fontan patients. So we perform flow measurements in the SVC and the IVC, right and left pulmonary artery, in the pulmonary veins and in the aorta. We can also perform flow measurements below and above a Fontan fenestration in order to quantify a Fontan fenestration. In order to calculate aortopulmonary or veno-venous collateral flow, we actually subtract the flow coming from the cava veins from the flow which we have in the aorta. And the difference we have, in this case without the Fontan fenestration, could either account for aortopulmonary or veno-venous collaterals. In the end, we cannot distinguish between those, so we try to actually take the clinic into account. If we have patients with cyanosis and calculated collateral flows, we rather think of veno-venous collaterals. If we don't have any cyanosis, we think of aortopulmonary collaterals. Or if we have no calculated collaterals at all, but cyanosis, it's probably rather arteriovenous malformations. In the near future, we're going to have an MRI-augmented cardiopulmonary exercise testing, thanks to PSD Herzfahrt, with the nice day of many biking trips. And by having this, we can actually also quantify QP to QS under exercise conditions and see how flow through veno-venous collaterals, aortopulmonary collaterals, or shunt volume is actually changing under exercise. Another topic is the measurement of pulmonary hypertension. There, actually, only cardiac catheterization is the gold standard to diagnose mean pulmonary artery pressure of higher than 25 millimeters of mercury, or the PVRI higher than 3 Wood units per square meter. There are studies who have shown a non-invasive estimation of mean pulmonary artery pressure, for example, by quantifying the duration and the size of a vortex formation within the pulmonary artery. However, non-invasive estimation of a PVRI is not yet possible. And much more interesting probably is not the question how to diagnose it, but actually what to do with those patients with pulmonary arterial hypertension and shunts, whether they're still operable or not, and what are the diagnostic steps for that. But I'm not going to go into detail with that, but it's probably going to be the topic of the next 2 days. Thank you very much.